So with that, we're going to get started. Here I have my co-moderator, Dr. Jay Cho, and our panelists here. We have Dr. Ben Colvard from University Hospitals Harrington Heart and Vascular Institute to our right. I have Dr. Lawrence Garcia and Dr. Peter Soukas and Dr. Drew Klein. The first case is being uploaded, I'm being told. So I'm supposed to be doing the second case. So I'm going to start the second case while we wait for the first case to come. Is that okay with you? Okay, great. So if you can get the first case. Okay. So the first case is a TADV case, and we're going to do this case in a way that we're going to make it interactive, and let's break it down in regards to, we're going to, in 15 minutes, we're going to make you guys an expert in doing DVA, deep venous arterialization. So I'm a consultant to Inari, LimFlow Inari, which is now a Stryker. They're the only company that have LimFlow or DVA or TADV. So bottom line is that what am I looking for when I decide to do a DVA, a deep venous arterialization? This is basically, now you have decided that these patients are folks that have no options. There are no conventional therapy for these patients, meaning that you cannot bypass them and you cannot fix them endovascularly. Those are the kind of patients that we currently consider for DVA. Not the people that you can do a bypass, not the people that you can fix with endovascular techniques. Anybody that's in no option, desert foot, and so on and so forth. Once we have made a decision that we're going to do the procedure, this kind of my mindset, which is actually very aligned with what we do when we do bypass or endovascular anyway. But it becomes even more important in the DVA kind of a procedure, as I explained it to you. So first is inflow. We got to make sure there is no arterial disease in the iliacs and SFA that is of significance, because that's going to impact the fistula that you create. Then is the fistula or the conduit. We got to make sure the conduit works. And for those that have worked with dialysis conduits, they know that sometimes the conduits can have a problem and they have to be corrected. The third aspect of this is the outflow. So remember, we have a conduit that we create in the calf, and then the conduit is giving flow to the foot. At the level of the foot, there could be issues such as a steel, stenosis, diversion of blood flow, and so on and so forth that we need to deal with. And I'm going to work through this with you today. So the first step in doing a DVA is a duplex ultrasound. It's a cornerstone of this therapy. We start with the duplex arterial ultrasound to assess the inflow, as we discussed. We then look at the tibial arteries. This is very helpful for us because we know what is open, what is closed, how much calcification there is. And then the most important aspect of the procedure, is a plantar vein mapping. Plantar vein mapping. That's when we use ultrasound to assess the lateral plantar vein, medial plantar vein, and decide where we're going to enter and start the procedure. Because this procedure, unlike everything else you're going to hear about in this meeting or in any meeting that you go to, starts from the bottom of the foot. That's how we start this procedure. So I'm going to talk through this with you with this case. This is a 73-year-old patient of mine who I treated about 9 years ago. The patient was as part of PROMISE 2. She has diabetes, extensive vascular disease, multiple stents, which I will show you in the SFA and POP. And she had these progressive wounds that are not very big, but they were present in the foot. They were not healing. And you can see her angiogram. You see that on the angiogram, she has, this is the AT. The AT is present. This is the TP trunk. This is the peroneal. There's a nice juicy peroneal here. And then the PT is totally occluded. Unfortunately, the peroneal cuts off right in the middle of the calf, and there's nothing. And she had a few attempts at another city in revascularization, was not successful. And honestly, anytime somebody is sent to me for DVA, I give it a try myself first, conventionally, to see if I can do it. And I had tried conventionally to revascularize this patient, and I had failed too. So I had convinced myself that there are no options available. So the first step, as I said, is the venous anatomy and the venous mapping. And I think it's extremely important to get a sense of the venous anatomy a little bit, and especially with duplex ultrasound, but also angiography, because the first step of the procedure is to get access in what we call the lateral plantar vein. So here it is, lateral plantar vein right here, getting access in the lateral plantar vein and coming up the posterior tibial vein to go up the calf. That's the first step of the procedure. And as soon as we get access, we take a picture. Now, the reason we take a picture is that it's very important to make sure that this arch is present. Because if you don't have this arch, you cannot get flow distally into the perforators and the digital veins, and it's unlikely that you're going to heal a wound distal in the foot. So understanding a little bit of the anatomy is important. So here it is, we got the access in the lateral plantar vein. We take our first venogram, and here we see that there's flow into the arch. And I don't know if this is a video or not, but bottom line is that we just want to see this. We want to see that there's trickling of flow in the arch, and the arch is available. We used to do this procedure 11, 12 years ago, actually starting at the ankle here. And that was a nightmare because we would go up, we would come down after 2.5 hours doing the case, we would realize there's no arch. So we wasted our whole time doing the case. So knowing that there is an arch right off the bat is very helpful, because if there's no arch, then it's unlikely that this is going to be a successful DVA. So once we have done that, then we have to get access in the arterial system. So here it is, we are getting access, and you can see this patient has had multiple stents in the SFA and POP previously. So we decided to actually get access here for various reasons in the proximal SFA rather than getting access in the common femoral. So we get access, 7 French system, we come down, and now we're going to make the two wires kind of meet each other. After they meet each other, and the way we do this, by the way, we have different sessions, we're going to discuss how we do that, but the way the two of them meet with each other is really using a needle in the arterial system, which we call the arc, and then we have a basket that catches the wire once you have gone from the artery into the vein. So there's a basket sitting in the tibial vein, there is a needle coming from the tibial artery, you poke through the artery into the venous system, you catch the wire in the basket, you externalize it. Once you externalize it, you go through a series of steps. You do a valvotomy to make sure that you have destroyed the valves in the venous system. Once the valves are gone, you do some angioplasty, and then you place cover stents from the calcaneal bone right here all the way to the DVA site. What's important here, and I wanted to emphasize in this session, is the fact that one is that you want to make sure you don't get any proximal steel. So you don't want to destroy the AT that was there before, and you don't want to destroy the proneal. So you see, I preserved both of those. And that's a very important aspect of this procedure, that you don't lose any active native arteries. Because if you do that, the patient is going to become very ischemic from this procedure. So that's the step one. Step two is that you want to make sure you have good flow in the foot. And here we thought we had a great flow in the foot. And you see there's these perforators and tributaries that are stealing blood into the lesser saphenous vein and the greater saphenous vein here. And these are things that you need to take into consideration, because you want to get the blood flow into the foot and not up the leg. So that's what we mean by distal steal. So there's a proximal steal and there's a distal steal that we need to address. And the way we do this is really with the ultrasound. We look at the ultrasound. So after we've done the procedure, the ultrasound becomes, again, very important for us, because this is how we assess how well we've done and is it working or is not working. So again, we want to keep an eye on the inflow. The inflow we deal with the peak systolic velocity and diastolic velocities, like you do in any arterial system. When you get to the fistula, you then want to look at the flow volume. And the reason we look at the flow volume is because flow volume can quantify the amount of flow in the fistula. When you're looking at just peak systolic velocity, you don't have a quantification of the flow. And the quantification of the flow is very important in the DVA, because if it's too high, there is a problem, and I have it here outlined for you. If it's too high, it's a problem because too high of a volume flow is going to overwhelm the digital veins and the perforating veins in the foot. You most likely cause inflammation and reperfusion injury, and it's unlikely that's going to work well. These patients get very sick, and I will show you what happened to our patient. If you have too low of a flow, that means that there is a problem with the patency. That means there is a blockage in the Either in the native arteries or in the fistula, there is a challenge. And then you want to make sure that there is no stealing going on in the venous system. So let me go quickly here. So this is a stealing situation. So when we do this ultrasound in the foot, we see that the velocity here is reasonable, 264. Suddenly it goes down to 30s. Well, something happened here. When we scan, we see, oops, there is a little branch here that is stealing from the lateral plantar vein in the foot. So the inflow is good, the fistula is good, but once we got to the foot, the stent didn't extend far enough to take care of this branch, and now we're getting a stealing distally at the level of the foot from the blood going into the distal foot. And the management of this, in the old days when we did this, was coiling. Now you can even put a suture externally and just deal with this right there and then. You don't even need to bring the patient back and do a coil. This is something you can do with ultrasound at bedside or even in an outpatient clinic. Very straightforward. So this was our patient. This was a little bit of a surprise for us, to be honest with you, because we thought that the inflow looked good, the DVA looked good. I thought we had a good flow distally to the arch, but the patient became very ischemic, you can see. Very angry foot, and even our velocities in the graph were good. So we say somewhere between 100 to 300 is reasonable. So we decided, we didn't know what to do, to be honest with you. This was early days of DVA. You know, there were a lot of colleagues across the board. We were talking to folks in Italy and United States, and like nobody knew exactly what was happening because things looked good. So we decided to go and coil some of these branches to see if we could improve the perfusion to the foot and try to make things a little bit better. So here we are, we did some coiling here, a couple of branches here, and the foot still wasn't looking great. We then went to the TMA. And one of the first things we learned early on, 9-10 years ago, was that when it comes to DVA, you cannot do primary closure. This cannot happen. This doesn't work. There's too much tension in these sutures and these staples. This destroys the venous blood flow, which we just created, causes necrosis, and it doesn't work. DVA has to be treated by secondary intention. Secondary intention. So it didn't work. We went, and this is how we learned. This was trial and error, honestly. We learned that, whoop, it doesn't work. When you put sutures and stitches, it doesn't work. We have to do this secondary intention. So when we released the suture, we saw that, oh, things are starting to improve. Then we had to go in to do some revision, and then we started seeing granulation. And what we learned was that if you do negative pressure wound vac on these patients with the low pressure, not high, even a high pressure wound vac can cause the veins to collapse. Tourniquet can destroy the veins. Tight dressing can cause compromise of blood flow. So there are a lot of things that we have learned through the years that you cannot do. This is a different procedure than one we are used to in arterial system. So here we go in then to the wound care, and you can see that the patient is doing well. It took a while, but this patient healed, and she's still actually doing fantastic 9 years later. And we actually just we are going to publish a paper with Dr. Patel, who is doing the next presentation, showing 3 cases that have now been 10 years out, 8 to 10 years out from DVA, still with their leg and still functioning very well. And these were patients that were scheduled for below knee amputation at the time there was an indication for DVA. So just to wrap it up, just a couple other things. Native arterial stenosis is a big deal. And the way we sometimes pick this up is when we look at the volume flow. If your volume flow is less than 100, there is a problem. And it usually means that there is an inflow disease. And sometimes it doesn't have to be very severe inflow disease. It could be even velocities of 300, like this case. So here there's a velocity of 391, I think, and you can see that the volume flow has significantly dropped. So pay attention to the volume flow in these conduits. This is another example of a steal. You can see that there's a steal going on here, and also the patient had a stenosis distally. So again, using ultrasound, we diagnosed the patient with a little bit of a steal and a stenosis in the foot, just using the ultrasound. And as you gain more experience in your centers, the ultrasound techs become more savvy with these. And then this is a high flow rate. This patient had as high as 1,000. In these situations, a little bit more challenging. Sometimes we do compression stocking like tubo grip, low pressure stocking to manage the degree of flow that's coming in trying to manage the high flow. So the high flow can also be detrimental in these patients. So as summary, again, patency is very important. So you gotta really pay attention to duplex ultrasound. Make sure that you keep an eye on the maturation of the conduit, and the way to assess that is by looking at the distal flow. There need to be some diverting of the blood flow, sometimes with coiling, and nowadays we don't coil anymore. Honestly, you can do it at bedside or in the hospital. And I remember that duplex ultrasound is extremely important. Thank you so much. I know I didn't leave a lot of time for questions, but I'm happy to take one or two questions if that's okay, Dr. Cho. Is that okay? Any questions about TADV? We have 7 seconds. Yes.
How do you do the ultrasound? Is it like recumbent, or you have actually putting the foot on the floor to see if putting partial weight changes that?
Yeah, we've been doing it recumbent so far, so we have not done the standing. It's you can do the standing on the calf, but you won't be able, obviously, to do it in the foot. So for those reasons, it's done recumbent. You're right. You know, in the flat position, and all the data I'm presenting is in that position. So, you know, all the data that we have captured has been in supine position. It's a good question, actually.
I have a quick question.
Yes.
So for patients who have concurrent SFA disease, is your algorithm for treating the SFA the same as your normal, you know, SFA occlusion patient, or do you have a different algorithm for treating these when you know you're going to do a DVA afterwards?
Yeah, I tend to stage this, in my opinion. The DVA itself, it takes a little bit of time to do it and experience. So I tend to stage and do the inflow first. I'll treat the inflow just like any other inflow. Like I go for the final treatment. So if he needs a stent, I put a stent. If he doesn't need a stent and he needs a atherectomy plus DCB, I'll treat the inflow like I would have done it if I was not going to do a DVA. Because I want patency. If I don't have good patency, it's going to affect my DVA. And then I bring the patient back and do the DVA. Sometimes I even wait a month or so. Maybe that's enough. And the wound is going to heal depending on the size of the wound and how the patient is suffering, you know, how big the problem is.
So Mehdi, I just have a question for you in terms of you underscore the multidisciplinary approach to CLTI. How long did it take you to get your entire vascular lab, your administration, your podiatrist, your wound care? I mean, you're only one person. You're a little busy. So how long did that take to kind of build that whole team?
It takes a long time, and we made a lot of mistakes. I lost patients because somebody used a tourniquet and the whole foot went black and necrotic. You know, we lost patients because there were sutures that were too tight. We lost patients. I mean, it was hard, and hopefully those experiences help others in this room, and that's why we are talking about this. But you're correct. It takes a while. It takes a team. It takes discussions and conversations and continuous, honestly, because even your podiatry, and we're going to have a lot of conversations about this tomorrow, even your podiatry community is not going to be familiar with this. They are used to primary intention. They are used to staples and sutures. They want to close these TMAs and these wounds, and the idea of leaving it open is a little bit difficult. Even the idea of dressing, like I said, even if the dressing is too tight, it can be detrimental in these patients. So I think that it's going to take time. It's taken us 10 years, and we still make mistakes sometimes, to be honest with you. So it's a continuous engagement and discussion.
Mehdi, I have a couple of questions. What is your normal protocol for follow-up surveillance with duplex? And if you detect thrombosis of your arterialized the fistula, how do you treat? Do you do lytic therapy, or is there any rescue measures that you take?
Yes, unfortunately, we do have experience in that. I hate to admit, you know, so these things do go down. And the surveillance is that we keep the patients one night. The next day, we do a duplex ultrasound to make sure that the system is patent. And honestly, the good news is that if there is a mechanical issue, these things go out that night. Believe me. So the next morning, you're going to get a nasty phone call, or not a nasty phone call, but a depressing phone call from your team that, oh, the graph is down. And you're like, oh, no way. I thought it looked good. So we are learning some things about that. And then after that, we do the ultrasound once a month, the duplex ultrasound, until things start maturing and stabilizing. And then I'll change to every 3 months. So I would say the first 3 months, once a month, and then every other 3 months until the wound heals. And then a lot of times, and we're publishing this, by the way, these graphs, they go down, but the blood flow and the resolution remains persistent. So we don't see recurrence of ulcers, and these patients do well, actually, at least in our experience and what we're going to publish soon. When they do have thrombosis, and this happens, as I said, we have our own experience, we typically so far have treated all of this mechanically. So with different mechanical systems, like when JEDI was available, we used a lot of JEDI through Abbott. We have used other modalities, Penumbra, through the Penumbra team. We have used other mechanical forms of thrombectomy, and overall they have done well. The main problem in these patients, almost all of them, have been the inflow transition between the tibial artery and the stent graft. Remember, these are 3-4 millimeter arteries. Our graft is a 3.5 to 5.5, and we think there is some infolding. As a matter of fact, the last case we did, Dr. Lee did a OCT, and actually we see the infolding of the stent graft. So what we are doing now, we change our practice. We place the DES, drug-eluting stent, from the graft into the native artery for that transition. And that has significantly helped reduce the number of stent thrombosis that we have. Okay, I'm sorry, I'm happy to answer any other questions. I'm already over. I'm going to hand it here to Dr. Yulanka Castro. She's going to present a case on LSAC, and then we'll take it from there. Thank you so much.
So I'll be talking about our Limb Salvage Advisory Council and how our team has set that up for our institution. These are my disclosures. So I'll start with a case. This is a case of a 65-year-old man with history of hypertension, hypothyroidism, chronic cervical spine pain that was undergoing an elective C2 posterior decompression infusion. And right after the initial incision, his course was complicated by a VT cardiac arrest. So right after the initial incision was an anterior incision. He had a cardiac arrest. He was able to be resuscitated. He went for urgent cath that showed a critical LAD stenosis that was treated. Unfortunately, due to his arrest, he did go into cardiogenic shock, required multiple pressors. However, he recovered quickly from that. Was able to be weaned after a few days with support. His EF was noted to be down about 30%, but while he was recovering, on day 7 of hospitalization, he developed modeling and pain in both feet and no detectable pedal signals. He was found to have an CTA, a 5.6 centimeter AAA with significant mural thrombus. And on exam, when he reported his symptoms, he was found to have already decreased sensation and weakness in his right foot, and just decreased sensation but no weakness on the left foot. So it would be basically a 2B on the right foot and a 2A on the left foot. And this is his CTA. As you guys can appreciate.
Yulanka,
yeah.
Was the cath done from a femoral approach or a radial approach?
Radial approach. Thank you, that's a good one. Yeah. So as you guys can appreciate, pretty significant AAA with a lot of thrombus, but overall, patent inflow on your CTA. And as we go down to the tibial vessels, that's when we see more decreased flow. But proximal tibials actually looked okay, but when you go all the way to the foot, that's when you can't really see what's going on really well. So we have an unfortunate patient which is going in an elective surgery and ending up with bilateral limb ischemia. So at that moment, when we face that type of patient, so I want to ask the panel first, have you guys encountered a case like this of a patient with, just clinically trashed foot overall from, any other clinical condition? And if you guys have seen it, how have you managed those?
Yeah. I was just thinking, whenever we see someone who's critically ill with feet that look like this, I think even with a large AAA, my first thought is that this is probably not necessarily embolic, probably related to their shock state and peripheral vasoconstriction. it's fairly rare for a AAA to embolize mural thrombus. Almost all AAAs have this mural thrombus, although it's not impossible for that to be a cause. My mind would probably still be thinking that this is related to pressors and their critical illness and not necessarily related to embolic problem from the AAA.
Yeah, I would go probably with an angio, but I'm curious, did they get a balloon pump or anything during their shock state? Because that may have sent a whole bunch of stuff south.
That's a good question. Thankfully, no, a balloon pump was not placed. But yeah, that was something that was initially debated, but since he was on low dose, pressors and was requiring less, no mechanical support was placed.
Yeah, I agree. They might be just pure vasopressor dependent. We've seen plenty of these where we do diagnostic angiograms and give a bunch of nitrates below the knee and all of a sudden their vessels look fine, but obviously when they're on triple pressors, it's a different story.
Perfect, thank you. Overall, our concern, we were concerned about either it was a combination of everything, having the AAA with thrombus, clinical, critical illness, cardiac arrest. But our major concern was that he was already having a significant motor deficit on the right foot and sensory deficit on the left. So we were, overall very concerned. We were thinking this patient was going to be heading for a bilateral below the knee amputation. So in our case, that's when we involved our team, and there's something that we have set up in our institution. It's called our Limb Salvage Advisory Council, or LSAC, where when a primary treating provider sees a patient that might be heading for a major amputation, that's when we want to explore whether there are options for management. That's when we, hop in a Zoom call, and we get into our entire team to evaluate whether there are other options for management of this patient. And this team involves vascular medicine, interventional cardiology, vascular surgery, and podiatry. And within this discussion, and we have this happen pretty quickly within the same day that these calls are set up. We all kind of give our opinion and try to understand whether this patient is, unfortunately destined for a major amputation, or if there are other options for limb salvage, either options for foot reconstruction, alternative therapies, or advanced revascularization. And the initial data on this approach was actually was published, and we were able, just for our first 19 patients that were presented on our LSAC, actually these were patients who were destined for a major amputation. That was what they were all going to have, a major amputation, but 9 of the limbs were able to be saved and successfully revascularized overall. So overall, this approach has worked, and this is just the initial data that was reported, but we can all, my colleagues in our institution, we can definitely attest of the importance of this collaboration and having a team that can, so that way decisions for major amputation are not unilateral. All guidelines recommend that management of patients with CLTI, since they're complex patients, should be multidisciplinary. And when we have, so that way the decision for major amputation is not unilateral, and we can establish whether there are other options that can be done to save this patient's limb. So this is what we did for this patient. Our decision with the team was likely the right foot, because of its dense motor deficit, was likely non-salvageable, but the left foot, given that it was just a sensory deficit, there was potentially some option for him and not suffer a bilateral major amputation. So we decided to do an angiogram of the left, as you guys can see, all patent ilofemoral vessels, but the main issue was that there was no flow past the mid to distal calf. On the right, there was really no flow. And we actually decided to proceed with intervention of the left foot with antegrade access, because the main disease was all intramalleolar. And overall, our target, our concern was that it was distal embolization. So what we actually, in this case, decided to perform, and this is Dr. Lee who actually did this case, was to actually perform thrombectomy of the entire pedal arch. And in this case, we actually used Jedi, and followed by balloon angioplasty. And this is actually post-procedure. So you guys can see still significant ischemic changes to the skin overall, but good intact motor function of the toes. However, we were going to follow the progress because we thought at least a TMA for this patient, but at least to have a functional foot. He did have a right BKA. Okay. And this were his ABIs, post-procedure. And then due to this, in following his progress, we still saw that the heel was lagging. Therefore, he went further intervention to actually help more of his pedal arch. And we're able to reconstruct his pedal arch and get him better flow to be able to heal to be able to get better flow to his heel. And these are the images of the progress overall. And this is after his TMA, and this is how the heel was looking later on. And he still has a long road, but you know, kind of all reassuring that we were able to provide him with this option. And overall thoughts that for a successful interdisciplinary limb salvage team, overall the culture has to be patient-centered, and it's something that we can attest in our institution. Overall cooperation, education, mutual trust and respect among various specialties rather than competition and judging. And it's very important when you have multiple specialties, you know, with different opinions overall. And overall, it has to come from the top down. We really appreciate our leadership overall that kind of leads that way, and it follows through with all the team members. Questions?
Thank you so much, Dr. Castro Dominguez. Any comments from the panel? What are you thinking, Peter?
So one question I had, Yulanka, is I'm assuming that with the obvious clot that was there distally, lytic therapy was not felt to be possible because he had just had cervical surgery. Was that felt to be a contraindication?
Overall, it was mainly, you know, that's an option as well that we've seen some patients actually respond to, but the concern was the recent surgery as well.
But I think one of the, I think the point of this case is that, you know, I think if you didn't have the support of the entire team, we probably would have just done BK. But it was that good conversation, you know, we have our surgical colleagues, we have our whole team, everybody's commenting, assessing the situation, and we are like, listen, this guy walked into the hospital for a neurosurgical procedure, and now is going to end up with bilateral low knee amputations a lot. Even if we can delay it, to be honest with you, maybe it's worth it, you know, a little bit of an intervention. And having that support alone, I think is huge. Because I think in most places, anybody taking this patient would be afraid that they get yelled at, because somebody looking at those feet would be like, are you crazy? These are gone. This is far gone, and you need to cut these legs off. So I think that, you know, in addition to obviously identifying all kinds of patients and the collaboration, it does empower you to sometimes push the envelope. And I think in this case, if it wasn't for that team, most likely we would have all, you know, individually, each of us would have said, you know what, it's too far gone, just cut it off. Yulanka, thank you so much. We really appreciate you. We're going to try to catch up a little bit because I went over. I'm sorry. Thank you. We're going to move forward here to Dr. Avkash Patel. He has an off-the-shelf TADV that's going to show us. Thank you, Avkash.
Good evening, everyone. Thank you for the opportunity to present this case. This is actually a patient well known to Dr. Shishehbor. I'm glad that he's here and he can fill in all the kind of holes that I leave behind. I have no disclosures. Dr. Shishehbor went over deep vein arterialization pretty extensively, so I'll kind of skip over all this. So this was a 55-year-old male who originally presented with a right second and third toe ulcer. He had prior history of a left below knee amputation 15 years ago, and he was also diagnosed with Berger's disease. He was an active smoker at the time when we first evaluated him. On exam, he had, as you can see, the ulceration on the second and third toe, no palpable pedal pulses. He did not have any sensory motor deficits. And these are his non-invasive studies, which don't look terrible, although his TBI is 0. He does have some dampened waveform on his PVRs around the ankle. Given there's a discrepancy between his wounds and his non-invasive studies, we took him for a diagnostic angiogram. And as you can see here, there's no significant inflow disease. Femoral popliteal segment looks fairly patent. There's some mild popliteal disease, but nothing seems flow limiting. Looking at the tibials here, you can see that the anterior tibial goes down near the ankle, but then it's occluded distally for perineal and PT, they're both occluded proximally, and there's very little flow going directly into the foot. There's significant amount of just collateral flow, but no named vessels or what we would call quote unquote desert foot. With this information, see what our panelists think.
I was going to ask the panel, I don't know, Dr. Cho, what are your thoughts here? This is a Burgers, we did a lot of vasodilators and high volume injections here at the pop level to try to see if there was some kind of a hibernating vessel. We couldn't see anything. It was truly desert foot. You can see, you don't even see a whiff of anything. There's a level of a collateral flow into the calcaneal area through that branch right there. But any thoughts?
I think you made a very important point about giving adequate dose of contrast, because when oftentimes you can visualize the vessels that are not normally visible when you give inadequate contrast. And if you're directly injecting into the popliteal and there's no vessel, I'm just curious, what's the contrast that you would inject in settings like this? How much?
Yeah, so we have different protocols. Sometimes we do 50-50 contrast. So in a 10 cc syringe, it would be 5 cc's of contrast, 5 cc's of saline. However, when we don't see the vessels, we then may go to all contrast. So 10 cc of contrast. If we are still like in this situation, because we really, the options were limited in this guy. And honestly, at that time, the DVA wasn't available commercially. So, and the patient was excluded from the trial. So we couldn't put the patient in a trial. DVA was not available, lymph flow wasn't available off the shelf. And so his options were very limited. So then sometimes we use a 30 cc syringe and try to inject with the higher doses. And that's actually something I learned from you, because we used to be much more conservative and not give a lot of dye, but we learned that, sometimes there's a lot of hibernating arteries and the higher volume is better. Drew, what are your thoughts? Anything else, about that foot and the folks with Burgers?
Yeah, I mean, I've seen a fair amount of Burgers with smoking. It doesn't classically have that corkscrew appearance. I agree with really I think it's really important to not take a shot from the common femoral, to actually get a catheter down and really take some selective shots with a whole bunch of vasodilators. But this is going to be exciting to see what you guys did here, because this sounds like you have a no option patient.
And by the way, we did try to, like I said earlier, we always try, so we did try actually twice in this patient, because I agree with you. I also felt the classic heavy corkscrew that you don't even know where you're going. It wasn't like that. So I was like, there's got to be a way to get this. But despite working hard on it and trying to get this revascularized, we were not successful. So, and also vasodilators and all that good stuff that we did. So what happened here?
That's a good question about the corkscrew appearance. The thing I did not say, that patient did have a couple of digital amputations as well, which was also kind of leaning towards Burgers disease as well. So we had, unsuccessful pedal arch reconstruction attempt. We discussed him in the LSAC committee that Dr. Castro went over. So essentially at the end of our LSAC, we kind of said that the patient should have percutaneous DVA. However, as Dr. Shishehbor mentioned, at the time this patient was being evaluated, we could not enroll the patient in PROMISE trial because of not meeting trial requirements. And of course, the device wasn't available for wide use at the time. So we decided to do an off-the-shelf percutaneous DVA. We started out with accessing the the lateral plantar vein, and then also femoral access as well. There's the angiogram, essentially. So we used the Outback device here to make our AV fistula from the just distal TPT trunk into the PT vein. You see in the middle image there, we inflated a 7mm balloon, used our Outback needle to poke into the balloon. Once we had successfully crossed over into the venous system, we snared the wire to access our through and through, to get our through and through access. We then performed venoplasty, and then also did used the LeMaitre valvulotome to kind of lyse the valves within the PT vein. And eventually we ended up using Gore Vibon stents and stenting across the fistula all the way down into towards the ankle. And as you can see here, there is good amount of flow into the foot. The pedal arch wasn't complete on this image, but we were able to reconstruct a complete venous pedal arch by the end of the case. The patient was discharged on Plavix and full anticoagulation. He did have some continued pain and there's some progression of gangrene, so we brought the patient back, performed an arterial duplex that Dr. Shishehbor kind of went over, and we did identify 2 different venous tributaries, and the patient underwent a coil embolization of one of those to improve flow within his foot. Sorry, slides are not advancing. Oh, there we are. Patient then underwent a TMA about a month later from the index procedure, and initially it was a open wound, which eventually healed over with secondary intention. This is his most recent non-invasive studies. The patient is almost near 3 years and without any symptoms, is ambulating with his prosthetic leg and is doing fairly well. And I think some of the key points here, Dr. Shishehbor kind of went over all of these. Patient selection is very key. Patients need to be compliant. They need to stop smoking. They need to make sure they're taking all of their medications as prescribed. There are anatomical criteria as well that Dr. Shishehbor extensively went over. I think it's also important to discuss with patients that they may initially experience increased pain, especially within the toes. They may notice some bluish discoloration, and over time, all of this gets better. But I think it's important to set expectations for the patients as well. In terms of wound healing, I think we'll have another talk tomorrow by one of our podiatrists who will go over taking care of these patients. But the wound healer typically is slower than direct arterial revascularization, so that's something else to keep in mind, and monitor volume flow. If there's any issues with wound healing, always bring them back, do a duplex, do an angiogram, figure out what else is going on with this patient. Thank you.
Great job, Avkash. Let's maybe we can take a couple of minutes to have a discussion. Questions?
Yeah, actually, I was going to ask you a little bit more, Mehdi. Obviously, you've been doing this for a number of years. I'm sort of intrigued that you had made mention earlier that traditionally you would be coiling some of these venous tributaries. So I was going to ask you technically your approach to do that, but then you also mentioned that now you're just ligating these. Maybe you could just give us a few more details about those particular interventions.
Right. So I think that early on, I don't know, sometimes, with technologies, like, you have to learn. You have to make mistakes and learn and, evolve. We thought that, coiling was the safest way to deal with this. And then somebody said, well, I can just put a suture from outside, like outside the skin, right, in the clinic, using ultrasound. And we also advanced technically with ultrasound. So like I was showing you earlier this morning, we can really see the steel with ultrasound. So we can know exactly where it is. So using ultrasound right in the clinic, you can put a Prolene suture right on that tributary or stealing branch and just, basically ligate it from
so you're
outside.
not making an incision.
No incision, just a needle
Just
goes
right through the skin.
Right, that's right. It's just that you have to have enough knowledge and be careful that you're not ligating the whole lateral plantar vein. So it's just that, there has to be a little bit of a skill as you figure this out. And it just ligates it, and that ends up thrombosing and get ligated. So that's becoming more and more common. The other thing is that somehow, I don't know why, the issue of distal steel is not a major issue for us as much. I don't know if it's the patient selection. I don't know it's the stent, because the stent we have a new generation of the stent. There's something that's happening that we don't deal as much with distal steel as we used to. So I haven't coiled a patient in 6 years. But in the beginning, almost every patient we were coiling. So maybe we were overcoiling and we just needed time. I don't know. And that obviously has been helpful because it's less cost and less procedures for the patient, so it's useful. Yes, question? Right. So it's a great question, by the way. I just actually reviewed the paper. I hope I can say this. I reviewed the paper. A group of folks looked at, arterial flow in the veins, and they looked at different aspects of the flow in the venous system in the foot to predict steel and these issues. And I mean, nobody has a large cohort of these patients. It was a small number of patients, but there was some interesting data that's coming up, pedal acceleration time, but they looked at the pedal acceleration time in the venous system, so in the lateral plantar vein, and they showed some nice correlations between pedal acceleration time in the DVA patients in the lateral plantar vein and the need for example, and steel, and the need to do some kind of a flow diversion. So there is some things coming out as we are learning and doing more of these ultrasounds in regards to predicting and helping us understand, do we have good enough flow so that we don't have to coil or ligate or those kind of things.
Mehdi, I have a question. It's obvious to me that this is a thing of evolution. Your intervention approach and all of this have been evolving over the past 9 to 10 years. I just wonder, in terms of a treatment indication, whether you see it, there will be a role for, let's say, failed TMA. If a patient undergoes TMA, primary TMA, and the wound does not heal, and I wonder if this deviant arterialization may be helpful in those patients who are not surgical candidates for revascularization.
I think this is a great point. I think that the technology can evolve to even a lower threshold settings if we can do it safely and effectively. We actually just published the 1-year data in JACC intervention last week, showing basically similar limb salvage rates as 6 months. And our 2-year data is going to be coming out very soon, hopefully, showing again persistent outcomes up to 2 years. So from a limb salvage standpoint, even as I said, and there's additional data that is coming out showing that in these patients, somehow there is venous arterialization. So even when the DVA goes out, there is arterialization of the foot. So when you do the TBI or TCPO2, the numbers have remained the same as when the DVA was open. It's pretty cool, interesting, what happens in the foot when you do this procedure. The key though is to keep it open for a while. Now that while is not clear. Is it 4 months? Is it 6 months? Is it 8 months? But we believe, at least based on the data that's available, that the first 3 months is key. You gotta keep these things open in the first 3 months. Okay, for the sake of time, I'm gonna move to Dr. Peter Soukas. He's gonna be discussing PQ bypass.
Thanks, Mehdi, very much. So if I could have my slides up, please. So this is gonna be a short and sweet, and sweet's gonna be the operative term for this particular case. So you'll see why in a couple minutes. So this is a 66-year-old woman, type 1 diabetic, hypertension, hyperlipidemia. She's had previous conduit use for a 3-vessel bypass. And over the course of 7 years, she ended up having 5 interventions of her left lower extremity.
Hey, Dr. Soukas, I'm so sorry. Can you guys give it a timer, please, to 15 minutes so we don't fall behind, make a mistake? Thank you so much. Sorry.
Thank you. You gave me 15 extra seconds. Thank you. So her first procedure back in 2016, she underwent orbital atherectomy, a scoring balloon, and DCB of the SFA. We also treated the left common femoral in a similar fashion. And she did well for about 5 years. And then she had recurrent disease, which we treated. At this time, we finally had IVL available, so we treated that with IVL and DCB. Did well for about a year or so. And then she had recurrent stenosis, and as you can see where we're going here, she had more IVL, and this time we said, well, let's maybe put some drug in there. So we put some Alluvia drug-eluting stents, and Unfortunately, she came back again. And so the next time around, again, as you'll see from the angiograms in a minute, because of all that deep wall calcification, performed IVL once more, DCB, and then in order to really try to get that artery open, we were a little aggressive to the point where we actually had a little bit of extravasation, had to do 2 prolonged balloon inflations. It looked like it sealed okay, so we thought, all right, let's get out of Dodge. Unfortunately, a couple weeks later, she came back and the stents were occluded. We ended up lysing her, and not surprisingly, when we cleared the clot the next day, we saw that she had had a flap there and there was some contrast staining. So at that point, had no choice but to put in a covered stent. We took a non-compliant 6 millimeter balloon inside that Viabond to like 28, 30 atmospheres, sort of a pave and crack type of attempt. Unfortunately, as you'll see here in a minute, that didn't work either. So she was left with a greater than 50% residual, and she was still having claudication after just 25 feet. So we lobbied our VAC committee, and they finally gave us the go-ahead to do a compassionate use case for DETOUR. So we were part of the DETOUR study, so we had enrolled a bunch of patients and were familiar with the technique. And as you well know, if you've done any commercial cases, you have to do vein mapping to assure that your femoral vein is at least 10 millimeters or you have a duplicate femoral vein so that you don't end up getting a DVT. So fortunately, her femoral vein dimensions were favorable, but she incidentally was noted to have an area of non-occlusive clot in the proximal popliteal vein, so we had to delay her case for about a month. After giving her a DOAC, repeat duplex showed that thankfully the clot had resolved. But at this point, she had now progressed from 25-foot claudication to the point where she was now having, unfortunately, rest pain at night. So we finally got her to the lab. So in summary, this is a patient with severe calcified SFA disease. Unfortunately, that precluded full expansion of the artery despite previous interventions using atherectomy as well as IVL as well as stents. And now she's progressed to Rutherford class 4 rest pain, not a candidate for open bypass due to a lack of conduit. So here are her initial baseline angiograms. Common femoral looks pretty good, but you can see there in those middle panels, there's still at least a 50% residual stenosis there, and despite the fact that that segment of SFA has been treated with hundreds of pulses of IVL and orbital atherectomy and balloons and high pressures and stents, still unfortunately you got that very severe area of narrowing there because of that horrific deep wall calcification. She did have a 2-vessel runoff, so we decided to go ahead and proceed with the DETOUR procedure. So for those of you who maybe aren't too familiar with it, typically involves putting a 7 French sheath in the ipsilateral. Usually we put in one of the paired posterior tibial veins, put a sheath up into the popliteal vein, and then it's an 8 French up and over contralateral femoral access. And then we do ascending phrenography. In her particular case, not only did she have a nice juicy femoral vein, she also had a duplicate femoral vein, which is extra bonus. So through the venous access, we then delivered an end snare, and you can see it's waiting patiently in the wings here for an 014 wire to come from the artery into the femoral vein, where the snare is waiting to accept that wire. So the crossing device, the re-entry device, is called an endocross. It's spring-loaded, so please be careful not to put your finger anywhere near it because it will pull a hole in your finger. And it's 15 millimeters long, so it's a spear, and it's long enough and has enough force that it can get through calcified vessels. So just, again, be very careful. So there's the endocross needle. We then advance an 014 wire. So we went ahead and snared that wire and exteriorized that wire. Proceeded initially with an angioplasty of that proximal anastomosis. We typically do this with a 4 millimeter balloon. A lot of people really like using serenator balloons to make the anastomoses. And so after making that anastomosis, bring the endocross back down from the femoral vein, go back into the above knee popliteal artery, and we typically try to line up the artery and the vein so that they're superimposed, and that really does help us decrease the number of throws that we have to make and makes the procedure a lot more time efficient. And so after we cross over, send that wire down into one of the tibial arteries, we'll typically dilate the distal anastomosis and then put a supportive 035 wire as far distally as we can in order to be able to more easily deliver the stent grafts, which are on an 035 platform. And we typically use a very supportive wire like a supercore. Dilated the distal anastomosis, and this is an angiogram just before putting in the last stent. Very, very important here to be absolutely, try to be as perfect as you can with your last stent placement. Remember that the top 2 millimeters of the device are uncovered, and that's on purpose so that you can be very, very aggressive about making sure that you do not miss the ostium of the SFA, because that's where you're going to get your ostial edge restenosis. And in fact, we kind of like the metal to be kind of just sort of a little bit over the bottom of the profunda femoris, the non-covered part, obviously, in order to really make sure that ostium is well scaffolded. So after delivering 3 overlapping stent grafts, we then post-dilate. Just like with Viabon, always want to be super careful about not dilating outside the margins of the stent, again, to avoid having an edge injury that could cause a restenosis at a later date. And unlike conventional stents where you may be used to doing, maybe 1 or 2 or 3 centimeters of overlap, for these devices, you want to have more like 3 to 4 centimeters of overlap. So an hour and a half later, we were able to achieve the percutaneous bypass, and you can see the flow going through the stent graft into the popliteal segment. And as you can see here, her PT came off independently off that popliteal artery, and eventually we were able to get 2 vessel runoff to the foot. So she was incredibly grateful, and she came in for her 1-month follow-up visit with a big box of cupcakes just to express her gratitude, and a very sweet note which said, "Thank you for my new working leg and foot." So that's my PQ bypass case. Questions?
Peter, you said,
Go ahead.
I'm sorry, you said that she wasn't a bypass candidate because of the cabbage, but you need a working vein to do this. So what was the turn down from the vascular surgeon?
Oh, she didn't have any, good conduit saphenous vein in either extremity for a conventional fempop bypass.
So it was more the surgical look of those veins, and the greater saphenous was used.
The greater saphenous was used for her cabbage, correct.
So for a patient with a below-knee popliteal artery target for, let's say, a bypass, how do you, do we know what the patency difference is between the PQ bypass versus using PTFE for a below-knee bypass?
Yeah, so there's now been 2-year follow-up data that were presented as part of the original Detour 2 cohort. So it actually turns out that they're basically about the same out to 2 years in terms of prosthetic bypass versus percutaneous bypass. So the 3-year data was submitted to CIRC Cardiovascular Interventions just last week, as a matter of fact. So hopefully we're going to have that data presented in the next few months. But it is basically about the same compared to traditional open prosthetic bypass.
Do you have any idea as to what, so actually this is very similar to, in a way, deep vein arterialization of the lower extremity, except that you are using the whole saphenous, femoral vein as a conduit.
Exactly.
Right? So I wonder what the bypass rate of conduit of the bypass patency rate would be if you were to use femoral vein as your conduit. In the setting, let's say saphenous vein is not available. And sometimes we harvest femoral vein to reconstruct the aorta, right? So I just wonder if we did the same thing and use the femoral vein as a conduit and do a either above the knee or below the knee bypass, surgical bypass. Of course, the patient will have to be surgical candidate for it, but I just wonder how that would compare with, with this.
In the Detour 2 trial, the incidence of femoral vein DVT was 4.1%, and it was discovered that in all cases where a DVT occurred, it was in patients who had femoral vein diameters that were less than 10. So during the course of the trial, it was the criteria revised so that you had to have either a duplicate vein and you had to have a femoral vein that was at least 10 millimeters. Now, I can tell you, in the real world, in commercial cases, that's not necessarily a hard and fast rule. You can pretty much get away with it if you have a femoral vein that's at least 8 millimeters. So I guess if you were going to use the femoral vein, as you suggest, I guess my question would be, what do you anticipate? I would anticipate that there'd be, issues in terms of significant swelling in the leg, and it'd be tough to, in terms of like the leg swelling up because you don't have a patent femoral vein.
Well, surprisingly enough, when we harvest femoral vein to reconstruct the aorta, deep vein thrombosis rate or leg swelling rate is not as high as you would anticipate. And if we are deliriously happy when we see saphenous vein that is 4 or 5 millimeters in diameter when we're doing bypass. And in this setting, when the femoral vein diameter is less than 8 or 6, it will be still usable as a conduit. And it may be superior to the Detour procedure. I'm just.
Yeah,
How much
I will say
segment?
that
I guess the question is that how much segment do you remove for aortic reconstruction? Because here, I'm assuming that you would have to take the whole femoral vein, right? You wouldn't be taking 6 centimeters or 10 centimeters. You would have to take all the way from the bifurcation down all the way to the knee, right?
Yeah, just above the knee.
Right.
Yeah, so that's normal.
Is that how you do it in the aorta too? Is that how much you take?
Yeah,
That's interesting.
Yeah.
That's interesting. Okay, any other question, Andrew?
Peter, I was going to ask, your post-management, are you sending these people home on Eliquis, Plavix, aspirin? What's your kind of go-to on these?
So, the IFU basically is dual antiplatelet therapy, preferably for at least 12 months. I think the folks who are doing a lot of this, if a patient, if it's a first time, everything goes great, you got great outflow, you can get away with dual antiplatelet therapy alone. But if a patient, if they have paroxysmal AFib or some other reason to be on anticoagulation, obviously we continue the Plavix as monotherapy. Or if it's a patient who does have any kind of an adverse event, whether it's on the arterial side or the venous side, these patients we're basically treating. And I think we've heard a lot of talk today about knowing the pathology of CLTI. It really does make a lot of sense to be treating these patients with low-dose rivaroxaban and a P2Y12 inhibitor. So we've really moved towards low-dose rivaroxaban and Plavix as kind of our standard approach for these patients now.
Thank you very much for your presentation. We'll move along. Next presentation will be by Dr. Andrew Klein on bioresorbable stents.
Great. Thank you, everyone. Thank you to the committee for having me do this. So I entitled mine for bioreabsorbable stents, biovascular scaffolds. I don't know. It just seems like acronym central here. Now you see it, now you don't. All right. So I have no conflict of interest, but I was a site PI for both trials, Life BTK and Motive BTK as well. So this is a case, again, just go through a quick case. This is a 76-year-old, actually husband of one of my partners. His nurse called me up and said, he's been having this wound for a year and he has diabetes. How many people have heard this story before? I have a non-healing wound for a year. Has anyone actually looked at the vascular supply? I probably can't see that from back there, but let's just say the TBIs are off, the toe pressures are low. For some reason, this patient has been left until he saw one of our best podiatrists who quickly ascertained that this was a concomitant problem going on. That's what the ulcer looked like in the after debridement before the intervention. You can see it's very pale based. It's on the medial aspect of the right foot, and obviously looking more combination that's not your traditional diabetic ulcer. So this was, I remember in May, I advised him, you should probably have an angio ASAP based on the way that looks. He declined because of a lot of things going on in the family. And I actually wrote out that in my note and documented it. And sure enough, 1 month later, he shows up in the ER, and that's his toe. And so obviously that's a little bit nasty. And at this point, that toe is going to come off. And as I stressed to him, the importance of the first toe for balance. So from in terms of podiatry side, we'll hear probably more about this later, that is the most important digit for balance. And so now that toe is definitely coming off. So to the bat cave or to the cath lab per se. And we do a up and over, a crossover. You can see everything looks pretty good here. But then below the knee, you can see he basically has very limited runoff. The anterior tibial is out. That's where the catheter, again, down. I usually take the infrapop pictures with catheter all the way down into the popliteal after giving vasodilators as well. So you can see not a lot of things going down there below. Fortunately enough, we were able to cross through the TPT trunk and then enter into the perineal, so it's posterior tibial. I used, again, chocolate balloons for below, and then eventually said, all right, how am I going to do this TPT trunk? What's it look like, again, with IVUS? And so this is what this looks like as you zoom in on the TPT trunk. Obviously, I left the anterior tibial, even though that would have been the better option. I said, we'll just try this for the angiosome. Let's just try to get flow down there and see what happens. So TPT trunk looks like it's a pretty good sized vessel. This is where IVUS again is going to make a huge factor here. And do we have any options? And so I thought this would be a really good case. Actually, one of the benefits of having a family member in the business is be able to get them into clinical trials, right? And so this is actually part of our life BTK trial patient. And what we're able to do is look at this for a bioresorbable scaffold. And so when it comes to that, you got to vessel prep, right? We knew this from the corners that if you don't adequately vessel prep a lesion for bioresorbable scaffolds, you're not going to get a good result. And so that's using high pressure balloon angioplasty. You can use whatever needs. I think I even use shockwave here as well at the end of the day. And then place 2 BVSs or DRSs or BRSs, you can call it whatever you want, in an overlapping fashion. And again, using IVUS for everything for guidance. And when we finish, we have 2 vessel runoff to the foot and a good inflow. Now you can see this is the final picture where you couldn't see anything before. So I thought this was a success for BVS because it's not going to be there in 2 years. And also I wanted to be able to leave the option open to go back to the AT if need be and cross more retrograde if needed. So why do you need BRS, BVS? We got to decide what we're going to call this. It doesn't matter what, because really what you're looking for infrapopliteal is a way to effectively treat it with perhaps with drug. We want to give a scaffold so that we don't have acute vessel recoil. And then ideally, you leave nothing behind, right? So bare metal stents, that's going to leave something behind. We're going to talk a little bit about this tomorrow. Stent fracture can occur. Same thing with drug-coated stents. Atherectomy and lithotripsy is a great option, but again, you may be resorting to a scaffold if you get an acute recoil. DCBs haven't worked to date down below the knee very well, and that may be for a number of reasons. We'll hear about that next. And angioplasty alone is relatively ineffective. So really what you're looking for is this idea of a drug that you can put there on a scaffold that will go away. And so the Esprit BTK drug-eluting reabsorbable scaffold is a temporary scaffold, again, that will reabsorb over time. It's now FDA approved and available. That's what it looks like, and it's you can go through the PLLA and what it is, and you can get really into the geeky science of this if you want to. I don't know much about it. I'm just a plumber and blow up balloons. But there's a lot of science here in terms of how you can make this thing bioabsorbable, but more importantly, you can actually see it. They do have platinum markers, so you can understand exactly where you are. I will say it's sort of looking like looking for the stents on the x-ray can be a little bit challenging. And so there is the study, again, Sahil Parikh and Brian DeBerditis were the lead investigators and published this in TCT and then at Viva last year. RCT trial, so when people ask me, well, what's the data for what you're doing? I actually have data. I actually had to present this in front of our STARS committee, or the people that basically say that you can't get any equipment. And I said, well, here you go. This is actually RCT data from 2 years. And so this is PTA versus a bioabsorbable stent. Again, FDA approved this device as of April 26, 2024. That data, again, was presented at Viva last year and TCT the year before. If you look at the data, what they were looking for wasn't just, I mean, here, I think Subhash made the point of going for need for not stenting in the past. I think that's really important, but here what we care about with CLTI is really, are you gonna limb salvage, and what's the primary patency, and what's your major adverse limb effects? And so as you look across, there's tons of outcomes that you can go through, and I'll just show you a few of them right now, if I can get this thing to advance. Thank you. Key inclusion criteria, I think this is really important. You can use a scaffold length, 170 millimeters, so that's actually pretty decent. I think most of us right now are putting DS, maybe 48 millimeter DS, maybe 38 millimeter DS. Lining those things up in a row, generally most of us want to stay away from that, but obviously in this realm you can feel free to do that because you get something that's going to go away. Here's your primary efficacy rate versus PTA. Again, 74% of limb salvage and primary patency at 1 year with intention to treat. And here it is at 2 years, so 68% limb salvage and primary patency, which is pretty impressive. I think across the board for these patients that are really sick. Remember in Best CLI, 30% of those patients, regardless, were dead at 3 years. So you're talking about an extremely sick patient population. Binary restenosis, obviously much better when you have a scaffold that's got drug on it. And then additionally, composite of male, interestingly, was 96% versus 91%. So this is where my committee of the people that divvy up how expensive things are going to be said, well, 2 years, does it really matter? It's 91%, 96%. And I would say that that's a survival bias, because if you live that long, you're actually doing pretty well. And then freedom from, again, clinically driven TLR. I think the point's been made several times here is I don't care if that area goes down after the wound is healed, because the supply-demand mismatch, because if we can keep it open long enough for the wound to heal, when your demand is really, really high, if that vessel closes down from PTA, or even in a BRS situation, again, as the wound is healed, that generally those patients will do okay. So this was the 2-year conclusion as published. And I thought it was fair that there was an advantage of using a BRS or DRS, depending upon what you want to say, for sustained vascular patency and limb preservation. It clearly works. The question, is it worth it? Is the cost worth it? And there's some cost-benefit analysis that you can look at that is available. And I think at the end of the day, compared to some of the other devices, as again, Subhash said earlier, all the amount of money we spend on atherectomy, I would say it is. Esprit BTK significantly reduces binary restenosis and limb occlusion. And again, it is a very safe option for our patients with CLTI. I think, and that's maintained out of 2 years. So if you have this option on the shelf, the question is, where is this going to fit into your armamentarium? And I'm going to turn to the panel for this. Is it always going to be your go-to? Is it going to be maybe when you have a patient that's younger? Or are you going to pull out your drug-eluting stent first, which are going to be relatively less expensive, and then use the Esprit BTK or whatever the stent, bioabsorbable stent may be later? And so I think from a technical tip size, I think these are like coronaries, IVUS, and more IVUS. I think you have to do it for below the knee. For mandatory vessel prep as well, you got to get a really good vessel prep. I don't care how you do it. You want to use atherectomy, you want to use IVL, it doesn't matter. You got to get a really good expansion of these stents. Of note, Esprit is not, because of the way it is built, really good for DK crush below the knee or any of that sort of stuff. So you do not want to be doing this for 2 stent strategies. You want to stick with your usual DS for that. And I think with that, I'm going to conclude with call them what you want. BVS, DRS, that's drug reabsorbable stent, bioreabsorbable stent, bioabsorbable vascular scaffolds. I can't even say these. Consider them for work for your BTK. I feel like this whole session has been acronyms. I had to ask Mehdi what he was talking about because I didn't understand it. So I think it's really important to understand for below the knee work with your CLTI patients that this is a really good option for your patients. Vessel prep, DABT may extend. I think it's really important that the on-label is 12-month DABT. That's different, right? So if your patient was a bleeding risk, maybe you don't want to use a bioresorbable scaffold. Maybe you want to stick with a Resolute stent where we can get away with just 1 month of DABT. And I think, as I've always told fellows, you either evolve or you become extinct. So understanding what new technologies, and I think this has been a great meeting for that, to really understand where things are going. And I think we're going to hear about that tonight as well with AI. That's going to be really important as we evolve as a group, as we take care of these patients, which are obviously very ill. And with that, I'll turn it over to the panel.
All right, Drew, thank you so much. That, as usual, you make it very provocative, and you're pretty humble dude. You know, I know that you obviously has had a lot of contribution to this field, and you're writing the guidelines. So, you know, the question is this. I'm going to ask a philosophical question here because this conversation, I think we've been beating bioresorbable all day long. And the question is that do we have a duty as a field to create an environment for new entrants and new business technology to enter the current model? What I'm saying is that, I mean, if you don't want to spend money, let's just do angioplasty. I mean, just bring these people back every couple of months and just do angioplasty on them. The reality is that, you know, that has cost, that has complication. We talked about this earlier, right? It has cost, complication, patient satisfaction. There's 1,000 things. So I think that, you know, we kind of need to push on the governmental side, but also we need, as a field, we need to demand that, you know, going back to what you said earlier, is that there's data. We need to be evidence-based. We need to support technologies that have the evidence and so on and so forth. I mean, that's my philosophy. I don't know, Ben, what are your thoughts on that, man? You know, how are we going to evolve and get new technology if we just don't want to use it because it costs too much?
That's the million-dollar question, because all the new technology is based on, you know, very expensive research and development. So we can't continue to have new technology unless we have the money to do that R&D. You know, I don't know, you know, what the right answer is to that. I guess you know, the other question is, when should we use it? And you brought this up. When should we use this expensive technology versus plain balloon angioplasty and tibial vessels? And I think one thing that, you know, maybe needs to be considered is the severity of the wound, right? There's people that you might see with a very small toe wound, you PTA the you know, AT, and by the time you see them in clinic a month later, it's healed. And so, you know, that's in contrast to the person with osteomyelitis who's going to need multiple, you know, podiatry surgeries. That person may need a longer patency. So, you know, I think one thing that needs to be considered is how severe the wound is and how long do you need that intervention to stay open.
Yeah, I'm hoping that machine learning and maybe some, you know, I just put in the chat GPT, how long should I do this for? Hopefully that will come out, because I think when you look at, you know, atherectomy and the cost and, oh, it's the avoidance of a stent. Well, then stent provides X number of dollars down the road because of restenosis, because of fracture. And if all of us have seen DS fracture below the knee, and it's a real pain in the ass when that happens, because then you got to deal with that in a smaller vessel. So the question is, how are we going to do this going forward? But Mehdi, your point is we have to be proponents for not only the technology, but for our patients. And that's why I personally went to this meeting myself and argued very strongly that we should have this on the show.
I would just simply, I was going to say that I don't know if I want to evolve or become extinct. I just want to put it out there. I'm right in the middle. I'm not sure yet. But for this is where I've always championed for every trial. We talk about durability. And the challenge is we don't know the failure. And again, failure mode, if you spend $3,000 for a spree, but it fails by peristent restenosis, then that's a victory because it's focal. But if you have a device which then closes by occlusion, i.e. angioplasty, then I think that should play a role. So we should have primary patency as X. The restenotic rates are whatever Y is, but how did it fail?
Yeah.
Which I think will then add to this whole discussion because now we know the outcomes.
Yep.
And that's what I think it's on us as scientists.
Yeah, what do you think, Peter? I mean, how can we be more smarter?
One of the other, the cost obviously is always, front and center with these discussions. And, Ben made a very good point. Like, it costs millions upon millions of dollars to develop these novel devices and then bring them through clinical trials and the regulatory process. And, the startup companies, they need to be able to recoup their losses and deserve to make a profit. But capitalism has been around for a long time, and as more and more companies get into this space, naturally, I think the prices will go down. I mean, Lawrence and I are old enough to remember, when stents first came out, and they were, $2,500 for a Palmage shot stent, and now I think I pay $200 for a Medtronic Resolute stent. Right? So as more BRS devices come on the market, that should drive the cost down and make it a little bit more tolerable for the accountants in the C-suites.
Well, in the interest of time, I think we should move along despite the interesting discussions. Next speaker is Dr. Anand Prasad, and the title of the talk will be BTK drug-coated balloons.
I think actually,
It's actually
our
Peter
speaker is Dr.
Monteleone.
Peter Monteleone.
Oh.
And don't mess with him because his last name is Lion, Mountain Lion.
That's exactly right.
So we have to be very careful. Here we go, Peter.
My apologies.
No problem. As Dr. Shishehbor said when I was a fellow, call Dr. Monteleone. Is there a clicker? Or? Yes, it's right here, my friend. Wonderful. Thank you all so much for being here. Thank you to the panel. I am not Dr. Prasad, who's wonderful, but I have the chance here to talk about a really exciting topic, which we've been talking about for years and is now getting even more exciting again. So the second coming of below-the-knee drug-coated balloon therapy. These are my disclosures. Importantly, I am a local site investigator on the Magical BTK trial that we're going to talk about briefly, unpaid, but a local site investigator investigating one of these new exciting technologies. The goal is to present a case and really bring this to discussion among the panel. So the case that we're presenting here is a 76-year-old gentleman, history of hypertension, hyperlipidemia, tobacco use, 40-pack year, long smoking history, who had a non-healing right anterior shin ulceration and a non-healing wound. You can see Dr. Edward Choke is actually his case presenting in therapy. When you think about drug-coated balloons, you have to talk about the excitement that brewed for a long time on drug-coated balloons, and also some of the results that we weren't as excited about when they finally hit the ground running. We've had so much success with drug-coating balloon technology. The folks on the panel have been really some of the leaders in drug-coating balloon technology clinical trials. When drug-coated balloons moved below the knee, the first pass in that work was, to be completely honest, not extremely successful. We saw that in the IMPACT DEEP trial. We saw that in the long-term follow-up, the Lutonix BTK IDE trial, and some other trials, including this Singa-Packley trial, which is discussed here. Prospective, multi-center, oftentimes randomized trials looking at utilization of drug technology in balloon form below the knee. Big trials, well-designed trials, thoughtful trials. In the setting of paclitaxel devices being used in that setting, though, when we looked at efficacy, we didn't see the efficacy benefit that we all kind of hoped to see when we extended drug-coated balloon use below knee. The key concept was it just didn't seem better. This was at the time where we were all thinking about Kitsanos and mortality risk with paclitaxel. There was no worsened mortality benefit, but comparing first-generation paclitaxel drug-coated balloons to plain old balloon angioplasty, we did not see a benefit. And honestly, when we looked at the long-term follow-up, so the 6-month follow-up in the Lutonix trial did show some benefit. The long-term follow-up, that benefit started to go away. Questions were also raised. There's some signal towards maybe an increased risk of amputation when we're using drug-eluting technologies below knee. There was a question that came up actually about this slow flow phenomenon discussed when you're using balloons, drug-coated balloons in very distal lesions. Not something that we've really necessarily thought about before. Nonetheless, despite all this data, this is a talk on drug-coated balloon utilization below knee. And the reason why is because we've reached the second generation of these devices. So here's our 76-year-old patient. Here's his angiogram. His perineal is patent. His anterior tibial is totally occluded. His posterior tibial is totally occluded. You know, clearly there's a limitation in perfusion getting down to that long-standing non-healing wound in a dangerous area in a high-risk patient. Unsuccessful at crossing the AT antegrade, unsuccessful at crossing the PT antegrade. And so we moved to retrograde tibiopedal axis. So first step was accessing and crossing that PT. You can see kind of wire retrograde crossing PT to provide that mechanism of getting across. This is also someone where we're thinking about the plantar loop, both as a treatment zone, but also as a territory to potentially give us the ability to cross and fix the AT in that vulnerable area at risk. So working antegrade in this case gave us the ability, after crossing the PT, to utilize the pedal loop to then cross the AT retrograde, and all of a sudden we have wire access across both vessels. Now, drug-coated balloon cases aren't always necessarily the most complicated cases in the world. At the end of the day, it's angioplasty. That's one of the powers of the technology. You know, we're not necessarily talking about short scaffolds. We're talking about longer balloons in different sizes that give us the ability to treat large territories. You can see in this case, a 2.5 millimeter sirolimus balloon was utilized to actually treat the pedal loop, and then more proximally, a 2.5 magic touch drug-coated balloon utilized to treat the AT. And suddenly, up top, again, 3 millimeters up in the proximal anterior tibial as well, and it allows reconstitution effectively of wonderful 3-vessel runoff, including a pedal loop into the foot in someone who's a very vulnerable patient. So we started off by talking about how the first round, the first generation, the first pass of drug-coated balloon technology didn't necessarily justify the excitement about this, but the case, I think, very clearly represents the potential power of this if we can figure out this technology. These long lesions in vulnerable patients who are going to need an extended period of time for things to heal. And so it's worth discussing this case and others is being done as part of evaluation within the next round of trials. So listed here and in your decks and systems, the Lyme study looking at a randomization utilizing the Magic Touch sirolimus balloon, the Magical BTK study, which we're actively enrolling into here in Austin, Texas. Welcome to Austin, by the way. A single-arm study looking at utilization of these balloons. The Prestige study also ongoing, looking at the solution balloon and its utilization. And being thoughtful, as you have to be when the first pass in these technologies didn't necessarily work, looking at a combination of diagnostic endpoints, clinical endpoints, safety endpoints, because we certainly have a lot to learn about this, and it seems like utilization of drug-coated balloon technology below knee wasn't as simple as it works in the FemPop. It'll probably work in the tibials as well. And so, as a result, I think this stalled out on me, but that's my second to last slide anyway. A lot of thoughtfulness going into the next round of implementation and utilization of these devices going forward. So thank you all so much. And I'd love to hear from the panel on this round of drug elution and how you're adopting it into practice, or what you're being thoughtful about in the next round of clinical trials.
Peter, thank you so much. You know, we have 3 minutes, you know, and, you know, I was just going to ask the panel here, Lawrence, we don't have a DCB below the knee right now in the United States. Any thoughts about, you know, what should we be looking for? There's some paclitaxel stuff going on. There's some sirolimus. Dr. Monteleone showed a sirolimus balloon. What are you going to predict here?
Well, I mean, if you go with the odds right now, paclitaxel is at a disadvantage, right? So it looks like sirolimus may be the next big step. And whether or not that is the victory or not, I'm not sure. But at the end of the day, I want somebody to win. We have the BRSs, we have the stent scaffold now with the spree. So we need more in that space, because right now angioplasty will save the AFS part of it, amputation-free survival, but it doesn't really, to the original question about durability, it's not there. So yeah, I want something to win that's not just a scaffold in this location.
Drew, Ben actually brought it up, but you also mentioned ChatGPT and AI and all that. Do you think we will ever get to a point where we can maybe image these arteries, use something to tell us, okay, maybe you're better off doing DCB here. Here, you should do maybe atherectomy followed by DCB. Here, maybe you should put a scaffold. Here, maybe you should put a regular stent. I don't know.
So I actually do think in the PE space, there will come a time, I think it will come there first, where a CT scan will be able to spit out immediately what devices are going to fit based on the angulation of everything. I foresee an easy way to put this up with machine learning, which is to send your CT scanner through machine learning and then say, you know, this based on what you have here, based on the imaging, you know, these are your options. I think it's going to give you a variety of options, and it will tell you kind of what the data shows, and then obviously what you got on the shelf. So I actually do think a couple years from now, maybe after you and I are retired, but there may come a time where people are walking in, they're saying, you know, we already have a plan coming and we already have the data, or we have ourselves on the shelf versus what we're doing now, which is, give me a 3.0 by, you know, something like that. I think that the time will come where it'll be automatic.
Hey, I was going to ask you guys, you know, our surgical colleagues, you know, here, do you think there is enough teaching? You know, we are kind of a little bit fortunate, I feel, this is my personal opinion, in cardiology because of coronary work. We are very much, you know, teaching constantly about imaging, you know, IVUS, OCT, hemodynamic, you know, FFR and all of that. Do you think there is enough of that going on in the vascular surgical field in regards to utility of, you know, OCT, FFR, IVUS in the periphery? I know obviously surgeons use IVUS for aorta and for May Turner and things like that, but do you think there is enough in the societies and in the meetings that are maybe more isolated to vascular surgery that there's enough teaching about these things, Jay?
To answer simply, it's desert foot. We have no, relatively speaking, compared to cardiology, there's very little teaching about these different imaging modalities or measures to assess the functional aspect of these lesions. That's what I mean by desert foot, yeah.
Yeah, I agree. I mean, beyond IVUS, I think that things like FFR and OCT are not part of a standard, you know, toolkit of most vascular surgeons, and I think that's, you know, more of a reason why a training program like what we have, where our trainees work with you guys closely, and, you know, we all work with each other closely and learn from each other, is that's just so necessary now with all these new technologies coming out.
Well, listen, any other comment, Peter, from you? You know.
No, you know, the whole BTK space, it's amazing how far we've gone and how much work there is to be done. You know, drug elution on a balloon holds this very practical application of it's well suited to the types of lesions we're fixing, long diffuse lesions across tibial vessels. But it's impressive to see the next generation of trials and how thoughtful they're being to make sure that we're not just going blindly down a road, that we already get some insights to the complexities of. So really excited about the next generation of trials coming down the line.
That's great. Well, thank you, everyone.